Okay, I think we are about ready. Well, good morning, everyone. I'm Dana Corson. I'm a media officer with the National Academies of Sciences, Engineering, and Medicine. On behalf of the National Academies, I would like to welcome you all to this briefing, those of us that are here in the room and those of you watching our live webcast. This is a discussion of the new report that was just released, titled Communities in Action, Pathways to Health Equity. This report is the first consensus study that is part of the National Academy of Medicine's Culture of Health program. The report is now available and it can be downloaded as a free PDF along with other related materials at www.nationalacademies.org/promote health equity. Also, the hashtag for those of you tweeting is hashtag promote health equity. This will be a 1-hour briefing unless we run out of questions beforehand. We'll start off with opening remarks to introduce the study and then give an overview of the report's findings and recommendations. We'll then open it up for questions from those in the room and via the web. Those of you in the room are asked to go to the aisle microphone to ask a question, and those watching the webcast can submit questions by typing into the Q&A box on your screen and then clicking the submit button. We ask that anyone asking a question, either here in person or via the web, please identify yourselves and your organization when you ask the question. And with that, let me introduce Victor Zhao, President of the National Academy of Medicine.
Thank you and good morning. I want to begin by expressing my gratitude to the committee and the staff for putting out this really important work. It is the first activity of the National Academy of Medicine's Culture of Health program supported by Robert Wood Johnson. I'm Victor Zhao, the president of the NAM. We formerly were known as the IOM, and I'm a physician and a healthcare leader, and I've been involved with many community health initiatives in my life, particularly the last 10 years when I was at Duke, and deeply involved with Durham community in North Carolina. And of course, realizing that healthcare was the only one piece of the whole puzzle. And I became very much involved with factors that to address social and economic factors that underlie health and also its inequalities. Now that I'm at the NAM, I've been really interested in linking community and population issues to policy decisions and bringing multiple stakeholders and the community together to craft solutions. And this is why this report is particularly important to all of us, but to me as well. Because we do know that a key factor for progress towards improving population health is establishing a culture of health in the community. The conditions that make up a culture of health include a shared value of health, multi-sectoral collaborations and partnerships, equity in environmental conditions that support health, and of course, health care and well-being as well, and importantly, equity in access to efficient and quality health and healthcare systems. Now, shortly before I started at the National Academy of Medicine, Dr. Risa Lavisa-Mori, the CEO of Robert Wood Johnson Foundation, and my predecessor, Harvey Feinberg, and I had a conversation about the idea of partnering with the Robert Wood Johnson Foundation to create a culture of health program. And as a result of that conversation and with the generous support of Robert Wood Johnson Foundation, we launched this multi-year program effort for culture of health. And what we want to do is identify strategies to create and sustain conditions that support equitable good health for all Americans. This report is the first activity under the NAM's Culture of Health program, for which the Health and Medicine Division convened a consensus committee to examine solutions to promote health equity, which is a key element, of course, in culture of health. Now, all of you know that health equity remains one of the most pressing concerns in the health field. You know, we have seen incredible advance in science, health, and technology over the last couple of years or decades, and yet at the same time, disparities are just widening and increasing within our country and other countries. Imagine we now have contact lenses that can measure glucose levels for diabetics, yet at the same time, we have families who can't access a nutritious meal for whom diabetes is the least of their concern until it devastatingly hit their family. So to credit Rose Martinez and her team, this report was developed with the following goals. To better understand the reasons why communities are not as healthy as they should be. In other words, we need to better understand the social determinants of health and health inequity. To better understand the root cause underlying inequity, what are those structural factors that contribute to this ongoing inequity? And to understand the best ways to move forward. What are the best practices, policies, partnership, and how can we spread the message and scale these effective efforts? So this report addresses so many of these issues. Recognizing the health equity requires a range of effort at community, local, state, and national levels. However, community-based solutions, which are the focus of this report, are necessary prerequisite for achieving health equity. Importantly, this report identifies a number of lessons learned from innovative community-led solutions across the country. I'm confident that this report will be a powerful resource for communities as well as policymakers at local, state, and federal level as they work to develop, in fact, evidence-based solutions needed for all to achieve good health and well-being, regardless of circumstance under which they were born, live, or work. And I know the committee's hope is that localities across the country can look to one of these 9 successful communities, one that may be similar to your own, as an inspiration to start their own action plan and model that works to advance health equity. The committee has stated that, quote, communities are uniquely situated to address health inequities by supporting a culture of health, which coupled with supportive local, state, and federal policies has the potential to create a more equitable and prosperous nation that offers opportunity for all. I just want to thank the committee again, really, for their great work and the staff for their outstanding support and the hours they have put into tackling this important issue. This multidisciplinary committee, 19-member committee, was chaired by, in fact, Jim Weinstein, who's here, and he will introduce some of the committee members today. But the individuals were selected for their expertise not only in health, medicine, but epidemiology, psychology, state government planning, philanthropy, business, private sector, academia, civil rights advocacy, education, political science, sociology, public health, bioethics, community development, and social policies. So I want to particularly thank the staff, starting with Rose Martinez, who's here, but also Amy Geller, Alina Basio, Yamrut, sorry if I pronounce your name improperly, Niguse, did I do well? Thank you. Sophie Yang, Anna Martinez, and Susan Barkin. I'd like to introduce, therefore turn over to Dr. James Weinstein, the chair of the committee and president and CEO of the Dartmouth-Hitchcock Health System, who will tell you about the committee and its work. And let me say again, thank you for joining us. And once again, thank you so much for doing such great work. Thank you.
Thank you, Victor. It's a pleasure to be here. Let me first thank the Robert Wood Johnson Foundation for their support. And I know they have some representatives here today that may want to answer questions for you as well. And thank them for the ongoing support of this work, as Dr. Zhao mentioned, that will continue after this report. Let me also thank the members of the committee that are listed here, and some with stars, other ones actually sitting at the table. But as Dr. Zhao said, this is a very diverse committee with varied backgrounds and brought a lot to the discussion that we'll have with you today. So I want to thank my committee members. As Dr. Zhao said, we had a really interesting charge as the first committee to really look at the disparities in the United States. This isn't a new problem. Maybe looking at some of the root causes and identifying in particular some case examples where we actually can move forward to make some real differences in society. And I think the 6 cases that we will talk to you about and that are in the report are just amongst hundreds that we looked at to present and provide these to you. We have conclusions and recommendations in the report. We'll talk about some of those today. That's not to prioritize these as more important than some of the different recommendations and conclusions, but we think they're helpful for the presentation. Looking for both short and long-term strategies to improve this work. And then finally, as you would expect from this group and this society, from the National Academy research, to actually understand and have the methods and tools by which we can study to make long-term changes to society is important. Like many of the committees, we hosted 3 informal gatherings for the public. We received broad input. We had experts from around the country come and speak to us about these issues. And finally, after having 5 deliberative sessions, we had an external review by 14 experts that are also listed in the report, mirroring the committee's expertise. In brief, the report is 9 chapters. There's 15 recommendations, not prioritized, but in summary, we all know this to be a crucial issue for the well-being and vibrancy of our communities and this nation. Health is a product of multiple determinants. As somebody who leads a health system, healthcare is interesting, and if you're sick, there's no better place to be. But most of health takes place in the communities, and that's where we want to get way upstream so that we can take care of things before they get to the acute healthcare system. Health inequities are in large part a result of poverty, structural racism, and discrimination. Those things unfortunately still exist in ways that we cannot imagine, and we need to discuss them openly, honestly, and create change. Communities have the ability to promote health equity, and you'll see some great examples of that in our examples. Supportive public and private policies are essential. Having community action is not adequate in and of itself, and having federal policy is not adequate in and of itself. So supportive programs working together, the collaboration and engagement of diverse groups is critical. And what we did is try to put some tools in Chapter 8 so that you can think about how your community can move forward on such opportunities. This is the conceptual model we put together. It's circular because these things are not linear. Obviously, back when WHO looked at some socioeconomic and political drivers, those things still persist, and the structural inequities in our system still exist. So we need to understand that we're talking about that framework and then taking the social determinants of health, which most of you are familiar with, the 8. We added the 9th of transportation because with some of the regentrification of our cities, we actually displace populations in ways that actually cause them to have more problems actually getting to a job, getting to food courts. So the unintended consequences of trying to upgrade our communities, change our tax base, et cetera, are affected in ways that we need to think about. To be successful, we looked at this in different ways. I gave you the context, this issue of equal but not equitable. We can give everybody in the community an equal size shoe, giving everybody a size 8. That's not equitable because everybody can't use a size 8 shoe. We can talk about social determinants, realizing that if we take on one, we only solve part of the problem, and that we need to think about the cross-fertilization of these together as we think about changing our communities and infrastructure. And then the key components that the committee thought were really solutions were making health equity a shared vision and value, and then fostering a multi-sector collaboration. You'll see in some of our examples that places like the Federal Reserve actually helped in housing in communities in California. Obviously churches, businesses. So it's multifactorial, multi-sectorial collaboration is where the successes come. And we added the third component being increasing community capacity to shape the outcomes. You have to have the tools. You can have a vision, but you do need that support from your community, federal government, local governments to help you. And then if you can do that, you'll see some of the desired outcomes will show you where a healthier, more equitable community is one in which individuals, families live, learn, work, and play together. In the preface, I wrote something that has been part of our country's foundation since 1776 in the Declaration of Independence. And our founders said that all people are created equal with the right to life, liberty, and pursuit of happiness. Equality and equal opportunity are deeply rooted in our national values, wherein everyone has a fair shot to succeed with hard work. But it doesn't happen that way, and I'm just going to remind you of statistics that many of you probably know, but you see a twofold infant mortality rate by different classifications of different groups, and these disparities are overwhelming. These are rates of death within the first year of life, looking at this twofold difference between African Americans and whites. Disparities in life expectancy are important to realize, and they can have a gap of about up to 15 years in men and 10 years in women. This is based on the economics alone. So for the top 5% of income earners, their life expectancy rose, while the bottom 5% saw no improvement. Geography matters, where one lives. These are variables that around death rates and life expectancies that are indicators of overall health of a community. And there's a 25-year gap here in just New Orleans, Louisiana, based on where you live. We can't have that kind of disparity when there's the opportunities to actually narrow that gap and coefficient of differences by just adopting some of these determinants of health and putting them together. The same thing in Kansas City, Missouri. A couple conclusions I'll just end with here before I turn it over to my colleagues are that the health disparities and inequities have profound implications for our nation. Our economic vitality is critical to this nation moving forward. The two facts on the bottom, some of you may be familiar with, but if we want to save money, we ought to take care of each other better. This work from the Urban Institute suggests that health disparities cost us $337 billion. Reducing such disparities would save $229 billion. Surprising to myself was that 75%, or 26 million Americans ages 17 to 24, currently cannot qualify to serve in our military due to persistent health problems. Issues that you're familiar with, drugs, both prescription and non-prescription, poorly educated, felonies, and health problems like obesity. This puts our nation's security at risk for unnecessary reasons. Again, the idea that people actually choose to have inequities is not true. This is not somebody's choice, nor a random occurrence. It happens because of the ongoing work that's happened in this nation over a number of years. And as this figure model from IOM in 2003, before it became NAM, actually shows that communities are important, but not sufficient. So the fact is, as I said in the, one of our recommendations about research and the need to create a data system where we can actually put this aggregated multi-disparate data into ways that become useful. People talk about big data, but most of it's disaggregated. We need to bring it together to mitigate the effects, to find explicit and implicit biases and try to eliminate them. I'll just show you a couple examples that were really exciting that we have in the report, starting with the Blueprint for Action in Minnesota, where their work over a couple years actually saw a 62% drop in gunshot victims, something that's a real problem for this country and the community. This kind of effect size is just huge, with 36% of the youth crimes going down and a 76% decrease in youth arrest with guns. The Delta Health Center was actually approached the issue of low birth weight babies and also saw dramatic decreases and started the first federally health qualified health center. The Dudley Street neighborhood in Boston took on education and saw dramatic changes in math scores, graduation rates, and enrollment in college. The East Side Promise neighborhood in San Antonio, Texas, saw child care go up significantly. And more importantly, there were safe places for the children to actually be in their neighborhoods. A critically important aspect of trying to have education is to feel safe. And just a couple more examples. In Indianapolis, a congregation got together to talk about how the residents could improve the incarceration rates and increase jobs. In Los Angeles and California has many examples. These are just a couple. Access to health facilities, graduation from high school, colleges, again, feeling safe to and from going to school, some of the things that many of us take for granted, people in this country do not. The Mandela Marketplace, which became a sustainable effort because of the way they set up the more or less a business to actually generate revenues to be self-sustaining and enduring by generating new food sources for the community. In Buffalo, New York, the Push Buffalo, which actually undertook the idea of looking at carbon emissions, utility bills, housing units to increase employment. And finally, in Harlem, the We Act group, which had new policies and procedures for harmful chemicals, pesticides, and flame retardants. And here's just a picture from the Blueprint for Action where they took on the issue of graffiti and turned it into art. Simple things can make great, great, great impressions. And here we see people being active in the We Act, West Harlem, against the sewage treatment plant. People do have to walk the talk. We can't just stand by and not participate. Participating can yield great results. So what are the guiding principles from the report? Don't try to start everything new. Leverage your existing efforts in your community. Adopt strategies that engage the community where they gain ownership in the problem. If they don't own it, it's unlikely to be successful. Nurture the next generation. Give them the excitement and the opportunity to succeed, and we think they will. Foster flexibility, creativity, and resilience. And seriously consider non-traditional partners. As I said, in California, the activities of the churches and the Treasury working together. Commit to results. As my friend Don Berwick says, having a result and an end date. You've got to have targets. We can't just spend money without clear results, targets, and learning and collaboration and capacity towards enduring and sustainable relationships. And partner with your public health agencies. Many of you are from the public health sector. I'm now going to turn the final slides over to Allison and Elizabeth. Allison?
Thank you. In our work, we looked at over 100 examples of community-based initiatives, and our recommendation comes out of the fact that there's just a lot of information held in these communities that could be leveraged into actionable knowledge by other communities, and to capture the evidence and to provide technical assistance to communities that want to tackle whichever social determinant of health is nearest and dearest to their heart, that they have a consensus around, in order to involve their anchor institutions, their businesses, their libraries, their Department of Transportation, along with their public health and health entities. So a recommendation is to have a public-private consortium that puts this information in a publicly available, preferably searchable, and it would be my thought, repository, so that communities can more easily access this information and get started. We have a section in the report that looks at the policy context in which communities operate. And while we maintain that communities can draw on their own power and have agency address health equity, the fact is that there are a number of policies and laws that shape their ability, that can impede their ability or enhance their ability to pursue changes in health equity. We delve into a great detail, frankly, into taxation policy and housing policy and transportation policy and so forth in this chapter. We have recommendations around some of these areas, not all of them. What we came to recognize is that any government agency involved in planning activities, whether it's land use or housing or transportation, should have a robust community outreach process to hear the community voice around their intended changes, to collaborate with public health to make sure we understand any unintended consequences for health, and to highlight co-benefits, meaning the win-wins. If you're making changes in your transportation, your public transportation system locally, that will have benefits in terms of physical activity and health improvements. And to prioritize affordable housing and to mitigate displacement. We also, our next recommendation comes out of this notion of win-wins and leveraging the new federal legislation around Every Student Succeeds, the Every Student Exceeds Act. In that act, there are requirements around community needs assessment and evidence-based improvement plans. Well, this is something that our nonprofit health systems know something about and have both data and technical expertise to offer. So we recommend that the tax-exempt hospitals and health systems and the public health agencies support their schools in collecting the data and developing those needs assessments. That's another win-win, and we recommend that the communities pursue in this multi-sector fashion. In that vein, given that there's such a profound impact on health equity, not just from the health system, but from the social determinants of health, we recommend that those nonprofit health entities that are designing their community health benefit plans focus upstream and long-term on economic development, on expanding access to housing, and take a broader view of community health needs. And finally, in this section, we have two important conclusions around civil rights and civil rights approaches to mitigating negative impacts of many forms of social and health discrimination, whether that's civil rights related to people with disabilities or veterans or women or around race. There are important approaches that have been used in terms of data and analyses and around thinking about the distribution of both benefits and harms that we concluded, based on the evidence, have made an important contribution in guarding against unjustified and unnecessary discriminatory impacts in programs that affect health. And now I'd like to turn it over to Elizabeth.
Thank you, Allison. So as Jim was mentioning, we spent a lot of time as a committee looking at the data. We spent a lot of time looking at the community examples, and as Allison was talking about, looking at the policy context. The other thing, just recognizing the importance of the community partners. And I think there's a lot of strength when you look at the examples, the 9 community examples that we selected from the 105 that we looked at, and also throughout the entire context, you can see there's really just so many different types of partners that can be at the table helping to forge these different types of community solutions. And of those, based on what we looked at, foundations and funders really were a key partner. We've seen some really tremendous work, just for instance, with the Robert Wood Johnson Foundation. And so some of the recommendations were that basically funders could also support community interventions to promote health equity in a couple of specific ways, really supporting community organizing around the social determinants of health. So again, the thing of moving beyond health systems, really supporting community capacity building, and that also was one of the 3 key areas. In addition, supporting education, compliance, and enforcement, as we talked about, civil rights was a really important tool to do this work. And then also just really prioritizing health equity and equity in the social determinants through investments in low-income and minority communities is really powerful ways that foundations could be a key partner in these community solutions. Another mention of the anchor institutions. So these are really the places that exist within communities that have, and often in we've thought about anchor institutions, and it's not always been in a favorable way of helping move communities forward in the right direction. But there is a great opportunity based on the capital that they bring in, the employment opportunities locally, and that they're there for the long run. And so we recommended that anchor institutions should make expanding opportunities a strategic priority as part of their mission and vision of the work that they're doing, and that could be accomplished through addressing the determinants of health in ways that they already are having an impact. And again, the emphasis through multi-sector collaboration. The other was just that assessing negative and positive impacts. So sometimes, anchor institutions have the unintended consequences, but I think really just being thoughtful about what their role is within the community and different ways that they're able to play a leadership role with the community at the table. We also, again, so many different partners. We've heard about the faith-based community, about public health institutions, but really also local policy. This is something that policymakers are making decisions every day in this realm, and that there's a really important opportunity to be using these lenses to look at how the policies and programs, initiatives, and especially funding allocations for programs have the opportunity to either improve health equity or not, and that putting emphasis there was really a key. So again, the last is that the community looked at things. This is all, as Jim mentioned, the community has a lot of power to create action at the local level. This does happen in the context of what's happening at the state and federal level, and there is the opportunity with the new Community Solutions Council at the federal level. So the community recommended that the Community Solutions Council, which is intended to support communities to address major challenges, really think about integrating health equity as one of the key priorities as their actions moving forward. And on that, I would like to say thank you and open it up for questions.
Thank you, Elizabeth. Dana, are you going to walk us through?
All right, so now we'll start our Q&A with the committee. If for anyone in the room who has a question, please go up to our standing microphone, and everyone on the web, go ahead and submit your questions. I will start us off with one to get us going. So what stood out most about the 9 communities you highlighted in the report?
Andrew, do you want to take that?
Sure. Thank you for the question. So the first point to make is that we didn't select communities, right? We selected initiatives in communities. And what we were looking for, what the committee was looking for, were promising examples. Both Jim and Elizabeth mentioned that we reviewed over 100 initiatives that we had reason through research and what folks had to tell us and our own experience had a reason to believe were themselves very promising. We were looking for the most promising examples of community initiatives that really showed that there is a space, there is in fact a space between the difficulty of this work and the impossibility of this work. Right, so these are communities that are making meaningful change with respect to health equity. We had several clusters of criteria that we used. The core ones were we were looking for initiatives that dealt with at least one social determinant of health, where again social determinants of health are employment, education, transportation, and so on. We were looking for initiatives that were truly community driven. Had evidence behind them, and were multi-sectoral, right? So again, worked in preferably in many different sectors, had partners in numerous sectors. And really, I think for the committee, the critical takeaway for readers of this report is that there is hope there, right? It's very difficult work, it's challenging, it's daunting, and still there is hope. Based not simply on an aspiration of work we'd like to do and like to see done in this country, but hope grounded in the fact that some communities are in fact doing the work. And they not only have the example, it's not simply scattered examples of work, but it's possible to derive the principles that guide the work that other communities might do, either to launch or to strengthen the work that they're already doing.
Thank you, Andrew.
Thanks
did you
for
get any
that.
questions, or should we?
Next. Oh, go ahead,
Please.
sir.
Hi, good morning, everyone. Dwayne Proctor at the Robert Wood Johnson Foundation. I want to take a moment, to thank the chair and the committee for this excellent work accomplished in a very short period of time, relatively speaking, and very hard-hitting and clear on not the connections between things like structural racism and health outcomes, and I think that's going to benefit us all very well. In your report, you stressed the need for multi-sector collaborations to come together and gave excellent recommendations on how that can be accomplished. And in some of the recommendations and conclusions, I also see you're connecting the social determinants of health and stating that you can deal with more than one at a time. And I was wondering if you can just kind of expand on that and the necessity of breaking down those silos and thinking across those sectors.
Thank you for your question, and I think it's critical that we break down those silos and connect the dots. Maybe I'll ask Ned to start.
I think it's an outstanding question, and I think one of the things we came to recognize is that circle in the framework of the social determinants, that they're all interconnected, and you impact one, and it has ramifications throughout the other social determinants. So as you start to think about interventions at a community level, some of them make a lot of sense. So if I was thinking about housing, low-income housing, transportation, employment, and public safety, they all, and the physical, you start to see how they're all kind of related. So if I worked on just one, I want to improve accessibility of low-income housing. I'm going to have to take all of those other things into account, and I'm going to have impact on things that could include employment, and employment could translate to income and wealth. So I think what we recognize is as a community impacts one, they impact the others. If you took on high school graduation rates or high school performance, you know, one of the key determinants of how long a person's going to live is whether or not they graduate from high school. And so you think about someone coming out of high school with better skills, and then community capacity, leadership development, and the ability to impact the community in which they live, we see the interconnectivity. So I think what we realized is that a community might have identified a single issue, and as soon as they started working on that, it encompassed the other social determinants, and they realized they could reach out to these non-traditional partners and say, you should come in and help us because we can impact all of the sectors in the health of our community.
Thanks, Ned. And I mentioned the transportation component that we added for the reasons I said, because as we change communities, I think there's the unintended consequences of who's getting displaced, and then what happens, and how do they continue on. Allison had a comment as well.
I just wanted to add to that we don't view, for that reason, these communities in any way as a recipe. Any given community can start wherever they want to in that circle around the social determinants of health. It has to do with what engages them, what topic engages their business community and their anchor institutions, and then move forward from there.
I think another big piece that we talked about is, as you know, at the core is sharing community value around the vision and the goals of where this is going. But there are a lot of the multi-sector partners who are doing this work and they're not necessarily thinking about the health equity implications. And so by reaching out and having that partnership, it just really is a great synergy to move this forward.
Okay, I think we have a question from the web.
So the question for the committee is, what are the most effective ways to ensure that the voice of ordinary people in the community are sought out, heard, and fully integrated into the design and implementation of initiatives?
I think we'll start with Lee and then Andrew.
Thank you. Such a great question, because it's so key to everything that we're talking about. One of the things that we discussed a lot is how can community participants be involved in actually putting together the evidence for what we know about what works. And that has not been the pattern in the past. But as we see how important it is to gather evidence about these complex, place-based, multi-factor initiatives, one of the things that we know is absolutely essential is to include the experience of the people who are directly involved, some as practitioners, but even more as the residents who are affected. And what we're talking about is not giving residents a token place at the table. We're talking about recognizing the essential nature of what they can contribute. And that has to be in making decisions about what it is we try to do, how we try to do it, and what documentation we can produce about what is working. And the inclusion of people who are not, quote, researchers in that effort is absolutely essential.
Yeah, there's a burgeoning field around participatory research and public engagement and so on. There are actually quite a few tools, and there are more and more coming all the time. I think, and we believe that perhaps the most critical element that's sometimes missing is the conviction that it really, really matters, right? That it is important that residents, that a broad swath of people who comprise the community, and that getting diversity at your problem identification and problem solving table is actually a crucial component of coming up with the best solutions. The best solutions meaning not simply those that sort of work technically, but those that get the greatest amount of buy-in and will be sustained willingly by the community members themselves. So part of what we try to do with this report is make that case. It's not simply a good idea. It's absolutely a necessary component if these solutions are to have traction and sustain themselves over time.
I would just add, I don't think this is unique to the issues of health equity. I mean, in any work we do, having people who actually do the job and live in the space be part of the decision making and forming the actual action arm is the only way to be successful. So I think this is clear here in the social determinants, but having the people on the ground who actually live it and breathe it so that they can find the key thing for them, like getting to school safely for my children, becomes the action item that's important. Please, Andrew.
Just wanted to add one more thing, because this speaks really to the importance of robust diversity, right, properly understood. These are complicated, right, these are complex issues, right? When you talk about, the production of health outcomes and production of health equity it's a complicated picture, right? It's a really complex picture analytically, and certainly in terms of fashioning solutions and implementing them. We have blind spots, right? Wherever we're coming from, part of the reason this committee is so large and so diverse in terms of disciplinary background and so on is precisely that the charge we were given is difficult and complex, and it takes lots of kinds of expertise and so on. And indeed, I think we would agree to a person, no question, that the product we came up with is well beyond what any one of us or any collection of us of similarly, sort of educated and folks could have come up with. And the same is true when you're dealing with any kind of complex problem in the real world, and certainly health equity in communities is one of those.
Elizabeth?
Yeah, I was just going to add to that. I think a big piece is recognizing the importance of community, but even within some of the recommendations and conclusions in the report, for instance, on the policy context of actually starting to integrate that community engagement should be part of the process, or the funding streams are part of the process as well on the foundation side. So I think there are a lot of ways to really integrate community in a very authentic way into the process.
And we've got a question here in the room.
Hi, I'm Bridget Kelly from Bridging Health and Community, and I look forward to reading the report in full. I really appreciate both the placing of all of these factors in a circle instead of a line, and also this conversation about really profoundly committing to the agency and expertise of the people who are most directly affected. So it's really great to see that conversation being highlighted in this way. One thing that has come up is how many of these other sectors that interrelate with health haven't been thinking necessarily, or are just starting to think of health as part of what they do. And I'm inferring from the first two recommendations that you spent some time thinking about how factors within the health system itself that affect the inequity of health from within the health sector. And my question is, did this committee have within its scope and within its thinking the ways that those inequities that come from the health sector affect inequities in these other things? So in other words, health also has an effect on income, opportunity, education, all of those things. So was that part of the circle? Were you able to get into that piece of it?
I'll start, and then ask Elizabeth and others to comment, but I think, yes. I lead a health system. It's fairly complicated, but I think if our system was really successful, we'd close our doors, right, because they wouldn't need us. And that's probably never going to happen. But the notion of getting upstream, as I said before, being in the community to help be preventative and or trying to get people from the acute system back into the community to be functional, so the issues of absenteeism, how they actually are performing in their job, understanding the social issues that surround their health. There isn't a patient I know that doesn't have a social component to their issues. I'm a spine surgeon. It's a complicated issue, back pain. So I think it's clearly important that we close the circle. These are not linear, as you suggested, and that's one of the reasons we use the circle. Elizabeth or Ned? Okay.
Yeah, I think we thought about it in multiple ways, and as you read the report, you'll see it kind of appear kind of as a separate concept of health and how health translates to improve social determinants, but then the opposite, that the social determinants translate directly to how healthy you are and therefore how much healthcare services you need. The other part of it, though, is as you look at the players and the anchor institutions and the role of healthcare systems, we really do talk about the rest of it. How does a healthcare system or a hospital show up in community beyond the issue of delivery of healthcare services, and really think more broadly about what is health and what should we be doing beyond? And I like the way you started. You said that they're just starting to think about that, right? And they've been prompted by policies and directions to start thinking that way. I don't think that's going away, because I'm very excited about how healthcare systems and hospitals are starting to say, we need to show up in community beyond the delivery of services. So a great question, and I think as you read the report, you'll see how it kind of weaves through there.
I think there's the unequal treatment report was one that delved deeply into the health system and racial disparities in the healthcare system. And implicit bias, for example, plays a role in those dynamics as well. Our lens is that implicit bias plays a role in a number of different places in the community that also impact health. So we stepped back and went upstream, and one can address implicit bias within health. One can also address it within education, criminal justice, and in other places.
We'll now move to another question from the web.
Question comes from Rick Juergens at Valley News. Do you have any view as to how the potential repeal of the Affordable Care Act will change the environment for pursuing the approach you suggest?
Ned, you want to start, and then Andrew?
I think it's important to acknowledge that policies that decrease the number of insured Americans will have an inevitable negative impact on overall health. From the standpoint of the report, I think there's actually a lot of hope, because we recognize that healthcare delivery is only part of the broader concept of how long a person lives, how well they live, their health and their well-being. And communities have the ability to address those independent of policies around health insurance. So I don't want to underestimate the impact that increasing the number of people without access to adequate health insurance will have on the overall health of our country and our communities. And I want to make sure that we're clear that there's an incredible amount of hope in this report on what we can do in all of the other social determinants of health in moving people forward, communities forward, and improving the overall health of our country.
That's exactly right. Really, the only thing I would add to that is, we have to remember, and we try to make this clear in the report, that communities aren't simply acted upon, right? They're not simply, sort of the state acts on local communities and the federal government acts on the states and on local communities. Communities are also actors in their own right, and they have influence not only within themselves, within the community itself, but potentially they can have impact outside their communities, right, outside themselves. They can, as it were, push up. And that's not only through, let's say, political means or power means, although that's certainly part of what they can do, but through the power of example, right? We have this idea of cities and localities as laboratories where innovation can happen and can be scaled up, or can be tested elsewhere. That's part of what we hope will happen here.
I think there's lots of examples that we've reviewed and looked at that started way before the ACA and will continue before or after whatever the next iteration of healthcare is. These communities want to change their lives for the people in where they live, and the public policies have both negative and positive impacts. But I think where the community makes those partnerships with the public-private sector, with the business communities, the anchor institutions that Elizabeth talked about, the likelihood of success is much greater. Elizabeth?
You said what I was going to say, so we got it covered.
We've got another question in the room.
Hi, I'm Laura DeStefano from the National Academy of Medicine. So I recognize that this is a very complex topic. There are a lot of actors involved. There are a lot of audiences. I would say that no single action is more important than others. But I do wonder if there is a way to prioritize. If you could say, if this group of people could do this, this would make the most difference. Or if there is the most compelling takeaway message that you hope comes from this report, can you articulate the actions that you hope will come from this report?
We'll start and just go down the line. So,
I guess I would think of those as what are the follow-on steps. And if I don't think we have any weights on these recommendations at all, so I can only speak for myself. But I think having that public-private partnership around the repository to be able to gather that information and not have every community reinvent the wheel, I would place a large emphasis on.
I agree. I don't think we prioritized one, and I don't think we have the evidence base necessarily at this point, which is part of the recommendations is to help build that. I would say on the multi-sector collaborative piece, I think there are, just as we had talked about, there are a number of professional organizations across the social determinants of health who are starting to really look at their place in these solutions. And so I think that finding and leveraging those key components are really a great next step to continue to build momentum in this. The other thing I would say is this is really about communities in action. So I think it's really about taking action, and that there is, as Andrew mentioned, this collective power at the local community level to do that.
I have to come back with the three things. So I know I was only supposed to prioritize one. I think we have to have communities that start with a shared vision and value that health equity is critical. So without that kind of shared vision and value that can be nurtured, I don't think we have the organic creation of community-based solutions. I think it has to be supported with infrastructure and capacity building to make sure that there are authentic partnerships with the people of affected voice. So there has to be that engagement of the affected voice in an authentic partnership approach. And then finally, I think for sustainability and success, you have to have multi-sector collaboration. Poor communities, low-income communities can have leadership development and develop capacity and do great things. And ultimately, they have to operate within the policies and the structure of the rest of the community. And so I think that the multi-sector aspect is key. So I realize that's not saying what should we do first, but when I would prioritize what I think are the real needs of creating a community-based solution to advance health equity, I think it's really reliant on those three.
I would second what others have said, especially building on what Ned has just said. If we're talking about a shared vision that includes a clear image of results, we're talking about building capacity, we have to be willing to accept the complexity of what we're doing. And the idea that there is a simple, one-dimensional answer is what we have to get rid of in order to have hope that we can solve this. So we have to be prepared to address not only multiple segments of our society, we also have to be prepared to collect the evidence and document what we're doing in a very much broader way than we have in the past. And if we can do that, if we can recognize the complexity of what we're doing, that will translate into building the capacity and building the hope for very clear results.
We reviewed 105 initiatives. As Jim said before we came into the room today, we wish we had 10,000 initiatives to review. And in 10 years, we hope we have 5,000, 10,000, more and more. The thing I would point to, the place my mind goes is to the visioning process. You know, I think we have a tendency to naturalize what is, right, the current state of affairs. We think if this is the way it is, it has to be this way. It doesn't have to be this way, right? A big part of what we try to show, or what the data show, as evidence, as documented in this report, is that, you know, health inequities, the state of health inequities in this country, some of them vast, you know, by race, by gender, by all sorts of identity, is constructed. It doesn't have to be that way. I would love to see more communities take this report, again, the examples, the inspiration offered not only by the 9 that we highlight, but by the many others that we name through the report, and say, what does this mean for us? What is the state of affairs in our community? What is our aspiration for our community in terms of health outcomes and health equity? And what are we doing now, and what could we possibly do to do better, right? To be having a different conversation in 5 years, 10 years, 25 years. I think that alone would go far toward, you know, realizing this dream of coming back and having far too many initiatives to review and gather further inspiration from.
I'm reminded too that RWJ is going to continue to fund this work through the National Academy, so more to come. But I'm also thinking of a project that I'm involved with the Department of Defense currently on building artificial organs with 3D printers. And Victor talked about technology. So imagine kidneys don't think of race or religion or geography, and doctors don't either when they're taking care of a patient. Technology will advance in certain ways we can't imagine, and I think when I'm talking about artificial organs through 3D printers, I'm talking about 5 to 10 years, not a lifetime. And as Andrew said, I think about these inequities being addressed. We need to exponentially ramp that up. And if we can go from 100 projects to 1,000 projects to 10,000 projects, then that exponentially changes what's happening in this society. So I'm extremely hopeful. And the merger of technology and social sciences and every other science you can think of, in this project I'm working on, it was just with a person who studies rocks on Mars. Well, what does that have to do with organs? But you'd be surprised. And so I think what I've learned from my colleagues and this remarkable group in this committee, it's possible. Now, the one thing is, I think getting the data of how these systems, these communities have become successful, and allowing that to be replicated in communities like mine, just like in genetics work, I mean, people like me. So we need to look at communities like me and try to replicate them because we're all different. But it's a great question.
Dr. Zhao?
Yeah, it's unusual that actually I talk about our own report, but I do want to really thank the committee and the staff. This is just phenomenal. As I think about what you do and the big difference that we're going to be making, clearly that I think an important comment that's been made, a principle you made again and again, this shared vision and collective action. Certainly on our part at the National Academy of Medicine, working along with our other colleagues, we are thinking really about how to disseminate this report effectively. And I think your idea of repository and the ability for people to come to a place to say, how do we do it? And how we learn from each other is very important. I think that's got to be an active way of doing things in moving it forward. I also think about when we did that report years ago in terms of quality, one can also argue, look, many things can be fixed locally in the way within your system. So in fact, what you're saying is we're going to find a system level that cuts across all those communities that people cannot learn. So I'm looking forward to some of those system level changes that can help the local community be effective. And finally, as I have done myself, been involved with these areas, I think leadership counts a lot. How do you begin that conversation in the community? One person, two person, how do you actually take this on whereby people then collectively come together, the vision? So your idea of cultivated future leadership, if not present leadership, I think is critical. Thank you so much for this great report.
So with that, we will conclude today's briefing. I would like to offer a special thanks to our committee members who joined us today. As you heard, they were representing the diverse expertise of the entire committee. As a reminder again, you can download the report and related materials at www.nationalacademies.org/promote health equity. Thanks again, everyone, for joining us.